So nice to have everybody here. So this talk is going to be mainly, as we discussed, going over psoriasis, a small overview, and then diving a little bit deeper into the current treatments that we have available, as well as what's on the horizon. So without further ado, let's get into it. Oh, sorry, what's going on here? There you go. Is that okay? Are you seeing it switch?
Yeah, looks good. Thanks.
Okay, good. So what is psoriasis? Psoriasis, it's an inflammatory condition that affects the turnover of your cells. So the regeneration of your cells, which usually leads to these thick, scaly plaques that can happen all over the body, but more specifically in certain places for the majority of people, which we'll get into in a second. It's very common in North America. It actually affects about 4% of individuals, and it's much less common in places like Africa, where it affects about 0.4%. It's a very chronic, long-term, tends to be lifelong condition that can go into remission, but it does tend to always recur. And it's inflammatory because it's caused by our own immune system. And you'll often hear the term autoinflammatory because it's our own immune system causing this inflammation. It's not contagious, despite what many people may think. And that's the number one thing when people say they go into public, they're often shunned because people think they have a contagious disease, which is very sad. And it is very treatable in the year 2022, but it is not yet curable, hopefully soon. So a little bit more about psoriasis. It tends to happen in two main age ranges. It could happen at any time, but it's very typical in the early 20s or mid 20s, I should say. And then again at around 50 and actually 60 as well. We see a lot of individuals coming in their 60s that are presenting for the first time with psoriasis. And the funny thing that everybody says is it can't be that because I've never had this before, but actually that is a very common time when psoriasis does present for the first time. Most people do, however, develop symptoms before the age of 30. And it's actually much more common for women to get symptoms before the age of 30 than men, but it does affect men and women equally. There are about 1 million Canadians that do suffer with psoriasis. And it's not just the people who have psoriasis, but it's also their families. If you think about it, again, these people from a psychological point of view may not want to go to public spaces. People think that they have a contagious disease, or even just a father that suffers from psoriatic arthritis may not be able to play catch with his son or daughter just because of the way that the psoriasis and the psoriatic arthritis is affecting his joints. The most common form, and we'll go into the different forms in just a second, is called plaque psoriasis. And about 90% of patients with psoriasis will have this type. 30% of people will get arthritis, which is what I was just talking about, and 79% of people will have nail changes as well. Access to treatment, it can be challenging, especially in different provinces and the territories. The coverage tends to vary. The cost of many of these treatments can be a bit prohibitive. So if you don't meet criteria for coverage, or if you don't have a good drug plan, that could sometimes affect what is available to you. Now, how does psoriasis work? It's multifactorial. So the exact cause is not quite known, but we do know that genes, the environment, and one's own immune system do play a role. Psoriasis, what causes psoriasis in one person may not be what causes it in another person. And it's actually much more complicated than we used to think. The genetic aspect, there's been a lot of studies done recently about this, and we see that if somebody has one parent with psoriasis, there's a 14% chance that they themselves will have psoriasis in the future or at some point in their life. If both parents have psoriasis, that number jumps to 41%. And an interesting study looked at monozygotic twins. So it's the identical twins, so they have a lot of the same genetics as opposed to the non-identical twins. And if one twin has psoriasis, it's shown that 75% of the time, the other twin will actually have psoriasis as well. That number is not 100% because, again, the environment and many different things like stresses and infections can play a role, but that number is quite high. So it does show that genetics do play a huge role with psoriasis. So these are just triggering factors. These are not causing factors, but if you do have psoriasis, things that can make it worse are stress, certain infections, trauma. So there is something called the Koebner phenomenon with psoriasis, where if you hit yourself or if you traumatize yourself in a certain area, you can get psoriasis that comes in that area. Alcohol, smoking, weight, and certain medications can also affect psoriasis as well. So the different types of psoriasis, the most common, as we said before, is plaque psoriasis. So this is 90% of cases. And as you can see there from the photos on the right, it does present quite differently in the different skin types. So in white skin, it tends to have more of a salmon colored appearance with what we call a micaceous looking scale. So it looks kind of like a mica rock. They're usually well defined. As you can see there, you see where the plaque ends and the normal skin begins. Whereas in the lower picture, you can see how it presents in darker skin types. So it can be a little bit challenging because it's not the same presentation in everybody, that's for sure. It can look a little bit more gray to even purple if it's very inflamed in some of the darker skin types. In the past, we used to think that psoriasis was something that wasn't really itchy. And if people said it was itchy, then it was more eczema or dermatitis. But newer studies have seen that 75% and even higher of people with psoriasis do have some kind of itch. Maybe not intense itch, but it can get itchy from time to time. If it's very inflamed, it can be painful. If there's a lot of, again, inflammation, if you're really scratching at it, the plaques can be very thick and raised off the skin, or in some areas of the body, like under the arms and in the groin, they can be flush with the skin. It's rarely found on the face, the palms, and the soles, although it can happen there, but it's more rare. And in normal individuals, like we said, this is a disease where the cell turnover is disrupted. So in normal individuals, it takes about 28 days for the skin to replace itself. And in psoriasis, it's about 3 to 5 or 3 to 7 days. And in more severe forms, it can actually be less than that. So here with plaque psoriasis, you could see the most common areas that it affects are typically the elbows, the knees. You could get it in the scalp, the lower back, or what they call the gluteal cleft. And you could also get your nails being affected. Like we said before, 79% of people with psoriasis will have the nails affected. On the top picture there, you could see the most classic appearance of what you would see in your nails. There's these non-geometric pits that you could get. Discoloration of the nail known as oil drop sign. It's like a yellowy kind of green discoloration. You could get lifting of the nail, something called onycholysis. And you could actually get a buildup of skin and flaking underneath the nail, something called subungual hyperkeratosis. You could see in the scalp there's one photo that it typically happens kind of behind the ears and around the posterior hairline, although it could happen anywhere, but those are the most common areas in the scalp. And in the skin folds, it could happen in anybody, in any different type of psoriasis, but it tends to look a little bit different, and we'll get into that in a second. So the other types of psoriasis, you can see on the right side there, that's something called guttate psoriasis, the top two pictures. Again, you could see how it looks very different in the different skin types. So it's more red, inflammatory looking in the whiter skin types. Whereas in the darker skin type, it could be more grayish looking. If there's a lot of scale, it could look very white. And if it's very inflamed, it could also, again, look very purple. Guttate psoriasis, as opposed to plaque psoriasis, tends to be these very small, almost like teardrops that could come all over the body. And it's very common after a strep throat infection, or is typically when it could happen. On the lower side there, the lower right-hand corner, you can see something called pustular psoriasis. We're not going to get into this. There's many different forms of pustular psoriasis. There's generalized forms, there's localized forms, but it's essentially where you get these little pustules kind of within and around the psoriasis. And when it's generalized, it could actually be life-threatening. So it's something that you should get on right away if that's what you see in your clinic or in the hospital. Inverse psoriasis, this is what I was talking about just a couple of slides ago. So this affects 3 to 7% of people. This is when psoriasis happens in the folds, so under the breast area, under the arms, and in the groin area. Because of the nature of these conditions, because it tends to be a hotter, more moist environment, you tend not to see scale. So as opposed to what we just saw, where it has that very white, thick scale, here it tends to just be flush, kind of red plaques, which could be why it's kind of difficult to diagnose in these areas. And then lastly, you could see down there, there's something called erythrodermic psoriasis, and this is usually a pretty severe form. It's quite rare, but it's erythrodermic means when it's essentially covering 90% of your body, so almost your whole body, and making you red essentially from head to toe. There's many different conditions that could do that, but psoriasis is one of them. Okay, so looking at how we measure the severity of psoriasis, there's many different ways to do this, but the most common way is just looking at the body and seeing how much of the body is affected. So we call this the body surface area. Uh, the way we measure this and how we look at percent is the palm of the hand is considered 1%. So typically when you're under 3 palms or 3%, you're considered to be mild. When you're between 3 to 10%, you're moderate, and above 10%, you're considered severe. So that's what we just said, that's the body surface area. There's something else that we commonly use in our clinics called the PASI. So this is the Psoriasis Area and Severity Index. The reason why this is good is because body surface area doesn't tell the whole story. If somebody has just one plaque, but let's say that plaque is on their hand and it's cracking, it's fissured, that could really affect somebody's function. They may not be able to hold a pen, they may not be able to throw a ball. So even though overall it seems like, oh, it's just 1% of their body surface area, it's mild, that could actually be quite life-changing for somebody. So what the PASI does is this looks at not just the areas of the body, but it looks at the severity in terms of how scaly is it, how inflamed and red is it. And again, it does take into account the body surface that is affected as well. So it's a more inclusive kind of score. And then lastly, we have something called the Dermatology Life Quality Index. And this is usually a questionnaire that the patient will fill out. And it's more subjective. It's based on the patient's obviously own feelings and how they're coping with the psoriasis and what their quality of life is. So it's actually a very important marker because this shows how the patient is coping with their psoriasis. And even though we as a physician may look at their psoriasis and say it's not that severe, if they feel that their quality of life is being severely impacted by this and they can't go out, they can't partake in daily activities, then that's a pretty good indicator that this maybe needs to be treated a little bit more aggressively. And this is something that we use to also get coverage for some of our medications, at least here in Ontario. Okay. So that was psoriasis and a bit of an overview. And then now this is getting into the treatments of psoriasis.
Dr. Corbo, before you continue, can I ask one question about the past section that just came up
Sure.
to me? Okay, super. My question is in terms of the different types of psoriasis you described. So because we have people who live with probably plaque psoriasis on the call, right? As part of the audience. Is it common for people who have plaque psoriasis to also get those other types of psoriasis? Is there a higher risk if you have plaque psoriasis for getting maybe guttate or other forms of pustular psoriasis, for example?
Yeah, they can happen together. So you can get plaque psoriasis with inverse psoriasis. It's interesting you brought up guttate. So with guttate, that tends to be, it's kind of an interesting type of psoriasis. It happens usually after infection with strep throat, but they do see that a very high percentage of people that get guttate psoriasis will eventually go on to get plaque psoriasis in the future. The reason why I say it's kind of interesting is because as opposed to plaque psoriasis, which tends to be lifelong, that one tends to come quickly after an infection, and then it tends to go away quite quickly within a few months. And they used to think that that was the end of it, but now they see that further down the line, like years later, they are more prone to getting plaque psoriasis. But yes, plaque psoriasis could also become pustular psoriasis too. If you irritate it, you can get pustules, or it can evolve into different types of psoriasis, yes.
Okay, great. Thank you so much.
Okay. So looking at the different treatments, now often a question we get asked is, I have psoriasis, what treatment is best for me? And the answer is, it depends. So it really depends on the patient. It depends on the severity, depends on, unfortunately, drug coverage as well, and what province you're in. They all play a huge role, and obviously how it's affecting you and your quality of life. Hold on, why isn't it? There we go. So it's really a conversation between the doctor and the patient in looking at what they've tried, what they failed, trying other things, because again, what works for one person doesn't necessarily work for another one, and then working through it together over time. Obviously, if somebody comes in and they're erythrodermic, that may mean that you jump to some of the other treatment options first. You may not want to try creams for something that's erythrodermic. But if somebody just has a few plaques here and there, then something like creams may be a good first place to start. So this is just kind of what we were saying. So type and severity of psoriasis, how widespread it is, benefits and risks, how the patient responds, and then individual preferences. So the different types of therapies that there are, there's many different ones. And actually we're quite lucky and blessed to be living in the time that we're in, because if you look 20 years ago, there was not that much. So there's been a huge explosion of newer medications and very effective medications, I would say, within the last 10 to 15 years. And you'll see that tonight. So there's topical therapies, and this includes things like creams, lotions, gels, ointments, and shampoos. So obviously, depending on where it is in the body, certain things may be more appropriate. So you may want to use obviously a lotion or a shampoo in the scalp because they tend to be a little bit thinner and easily worked into the scalp. Whereas if there's a very thick plaque on the hands or the feet, you may want to use more of an ointment. And some people don't like being greasy, so for them, creams might be more suitable. Beyond that, then we have something, oh, sorry, something just popped up. I think there's a question there, but I'll get to that in a second. So a step beyond that, we have something called ILK, and this is intralesional Kenalog, and that's essentially an injectable steroid. I find this quite beneficial for very thick plaques, usually when the patient doesn't have too many, so like a thick plaque in the scalp or a thick plaque on the knee. This is obviously not appropriate if somebody has, let's say, guttate psoriasis and they have hundreds of plaques or little papules. You're not going to go injecting each and every one. There's something called phototherapy. So this is light therapy. We'll get into this more in a second. This is a very effective, it usually tends to be very effective, and it's a very useful therapy. And then there's systemic therapy. So these are oral medications and injectables, and we'll talk about that a bit more as well. So the topical treatments, there are many, and a lot of them have their own role in today's world and can be quite effective. So this includes things like coal tar. We don't see that used quite as much anymore. It used to be used a lot more in the past. Vitamin D analogs, steroid creams, a combination of steroid and vitamin E, or vitamin D, excuse me, or steroid and tars, steroids and retinoids. And then you can see there's retinols or retinoids, salicylic acid, and something called calcineurin inhibitors, which we'll talk about in a second. So coal tar, the way that this actually works is it helps to slow the skin proliferation in the area where you have the psoriasis down. We typically see this in shampoos where you have very thick plaques in the scalp. The downside or the drawback is it tends to smell like tar, which may not be appealing to some people. Vitamin D analogs, these could be quite useful. We see this in a lot of different creams, mixed with steroids or on their own. And again, they slow down the skin cell growth, so they help with psoriasis in that sense. Steroids, which I'm sure many people know about, this is a very popular choice for many physicians and specialists. They're powerful anti-inflammatories, so they really help to take down the inflammation, which helps to take away itching and pain if the patient is experiencing that. They help to constrict blood vessels, so that's how they reduce inflammation in that sense. And they also slow cell turnover. So they could be quite useful with psoriasis, but you have to be careful. If they're overused, they could also lead to things like skin thinning. So you just have to use them as prescribed and don't abuse them. Combination treatments, we've already talked about. Retinoids can be very effective because, again, they help with the turnover of cells. We don't completely understand the mechanism of action, but it's thought that they slow the skin proliferation down. So they help in that sense with something like psoriasis, where the cell turnover is a little bit higher. And then lastly, we have something called calcineurin inhibitors. And I find these very beneficial for areas where you don't want to use steroids. For instance, in areas of thin skin, like on the face, under the arms, and in the groin, they can actually be quite effective. So the names of these are tacrolimus, which tends to be more of an ointment based, and pimecrolimus, which is more of a cream. This one is the intralesional Kenalog. We kind of touched on this before. So this is very effective for smaller areas of the body that have thick plaques that maybe aren't responding so well to creams. And because it's such a small area on the body, they may not want to do an oral therapy or go for light therapy. Let's say it's just a plaque on the elbow. It may not be worth it to get light all over your body just for one plaque. So in those instances, it could be very beneficial that it's very localized. It gets to where it needs to be, the medication, and it just affects that one plaque without affecting the rest of the body, like an oral medication might. And now we have phototherapy. So I'm going to plug our own office here. We have phototherapy at our clinic. So I have a lot of experience with phototherapy, and it's one of the treatments that I absolutely love. It could be very useful. It's very safe when done properly and under the proper supervision. And this helps to slow the growth of skin cells and reduce the inflammation that we could see with psoriasis. Depending on where you are in the country, it could be publicly covered. Here in Ontario, it is publicly covered. So the only thing you would usually pay for is the goggles to protect your eyes. And if you, let's say, live far away, 2 hours from a clinic that has it, it is something that you could buy over the counter or at home. But the cost tends to be a little bit higher, and hopefully your drug plan would help you with that cost, but that's not always the case. There's two types of phototherapy. So there's UVB, which comes as either narrowband or broadband. Usually narrowband is what's used. It's a little bit more effective. And then there's UVA, which is ultraviolet light A. And this is typically when you take a medication, usually something called a Psoralen, that sensitizes you to the light, and then you go in front of the light, and it's a bit more effective in that way. The one that we have at our clinic is narrowband UVB, and I find this to be quite effective and quite safe. It's typically 2 to 3 times a week that you would do it for about 30 sessions, and you typically get long-lasting benefit, like about 6 to 12 months of clearance. At least you're supposed to. If it comes back after a month or so, that's considered a failure. Just to touch a little bit more on the over-the-counter units, obviously read and follow the labels. Every company is going to be a little bit different, so you want to make sure that you don't burn yourself. Again, it can be a little bit expensive, but if you have a drug plan, they may cover some or all of that for you. So you may want to look into that. The one problem I have with this is that they tend to come as single units. So you either have to kind of go over your own body with it, or have it at a specific part of the room and then kind of turn yourself accordingly. Whereas in the medical clinics, and I know it might not always be possible, but they tend to have these large units that surround you, so you get an equal amount of light to all parts of your body for the same time. So you just have to be careful that if you're doing that at home, that you don't overlap too much so that you don't burn yourself or get some of the side effects. And then we have the systemic therapies. So this will typically use in instances where somebody's a bit more severe, or they failed some of the more conventional therapies or topical therapies, and they continue to struggle with their psoriasis. These are available by prescription only. You can't get these over the counter. And again, it's used for moderate to severe cases. There's oral medications, and there's these newer medications called Biologics or biosimilars, and more of these are coming out every day, and we'll get into that as well. So for the oral therapies, some of the therapies that have been around a little bit longer are oral retinoids. The name for this is acitretin, or you may know it as Soriatane. There's a few, that one is just the brand name, the other one is the generic. The way that this acts is it's a pill, and you take it, and much like the cream, it helps to reduce the production or proliferation of skin cells. I find this to be quite effective for psoriasis on the palms and the soles. That being said, I find it's probably the least effective option for psoriasis on the body, but it does have its role. The next two options you could see there, methotrexate and cyclosporin. These ones, they can be quite effective, but they block off a larger part of the immune system than some of the more targeted therapies. So you just have to be careful with more of the side effects that these could cause. When done by your physician and when monitored properly, they can be quite useful and very effective. And then at the bottom there, you can see there's something called the Premolast. This is a PDE4 inhibitor. The brand name is called Otezla. And this is a type of pill. It's taken twice a day. And it is usually quite effective. It can be quite effective, especially for palms, soles, and scalp. But there are certain side effects to have that can happen, with this medication. One of them being depression. So if there's a history of depression, you may want to talk with your doctor a little bit more about that. Sometimes weight loss, which people usually don't mind too much, upper respiratory tract infections, or headaches. But it's usually generally considered a pretty safe medication. Then we have some of the newer treatments. So these are called biologics and biosimilars, and they are by typically injections. They block certain areas of the psoriasis pathway, which I'll show you in a second. And that's how they work. So they block these different inflammatory molecules, and they're usually very targeted to kind of stop psoriasis in its tracks and having the effects that it has on the skin. So it's usually used for people who have failed to respond to traditional therapies. They can be a little bit expensive. So usually your drug company or the government will want you to fail certain other therapies first before they would cover you for these medications. But these have been around for quite some time in one form or another. We've been using these for about 10 to 15 years now, and their efficacy and their side effect profile is pretty well documented. So it's not like these are brand new. They've been around for some time. Okay, so there's many different classes of biologics, and I'll just show you this schematic here, this diagram, because each of the biologics kind of works at a different part of this pathway. I'm not sure if you could see my mouse. Can you see that there?
Yes, we can, Dr. Corbo.
Okay, so at different parts of these pathways, so for instance, the TNF blockers may act a little bit more upstream, blocking over here, which then leads to blockade of cytokines downstream that would affect the proliferation of skin cells. It's a little bit technical, but it may just help you to visualize where some of these drugs are working. There are things called IL-12 and 23 blockers, which, as you can see, they kind of act at different places to stop these inflammatory cells from having the effects that they have and essentially causing psoriasis. So these are a little bit more targeted in that sense, these biologic agents. Actually, just getting back to this, I think a good way to think about it is, and I can't take credit for this, one of my mentors actually kind of put it into perspective. His name was Dr. Neil Shear. He said, look at it as your immune system being like a tree. So you have the trunk of the tree, then you have the larger branches, those go into the little branches, and then eventually the tiniest branches. The medications that we used to have can serve their role, but they kind of block off a larger part of the immune system. So that's almost like cutting off one of the larger branches. So it'll take off if you have like a disease branch, it'll take that off, but it could also have other potential side effects. You could leave a big hole in the side of the tree. It could leave the tree open to certain other issues. Whereas these biologics, they're almost like going directly to that branch or to the smaller branches and kind of snipping those off at the source. That's not always the best situation. I'll get into that in a second, but they're very, very targeted. And in that sense, you're not affecting the rest of the tree, and the side effects are more minimal. So the first class of biologics, and these have been around for quite some time, are called TNF-alpha inhibitors. There's many different types. There's one called adalimumab, etanercept, infliximab. They all work in a kind of a little bit of a different way, but they're either by injection or infusion. And if you could see from this schematic, they block off that inflammatory molecule called TNF, which could play a role within psoriasis. So if you block that off, you block off certain inflammatory molecules that are then going on to cause psoriasis. So it helps to stop it in that sense. These ones, because they've been around for a little bit longer, the patent on a lot of these is now starting to expire. So we're starting to see these other drugs come out called biosimilars. And these ones are not identical, but they are similar to the drugs mentioned above. And they're quite effective as well. They're usually a fraction of the cost. They're a little bit different than generic, and I'll tell you that in a second. There's a slide on that, but they can be quite effective and quite cost effective as well. The next category of biologic is called IL-12 and 23, and this is one drug known as ustekinumab. It's also known by the brand name of Stelara. This is an injection, and it's every 2 months. It's relatively safe, and its efficacy is very good as well, but there are newer medications that they also have the same side effect profile and are quite effective that we'll see in a second. Then there's IL-17. Again, this is another inflammatory cytokine that's involved within the psoriasis pathway. These medications, they act to block this molecule so that, again, it doesn't go further down the pathway and cause the production of skin cells that leads to psoriasis. The good thing about this class of medication is it tends to be quite rapid. So within a week to 2 weeks, people that take IL-17s, they notice that their psoriasis is going away quite quickly. Whereas with some of the other medications, although eventually they may be clear, they may take somewhat longer, like 1, 2, and sometimes 3 months. Examples of IL-17s are secukinumab, also known as Cosentyx, izokizumab, also known as Taltz, brodalumab, which is known as Siliq, and something called bimekizumab, which is Bimzelx. The side effects with this, you do not want to use this if you have an inflammatory bowel disease. So if you have something like Crohn's or ulcerative colitis, it could be negatively impacted by the IL-17. So again, discuss that with your doctor. This may not be the right category for you, but if you don't have those things, it could actually be quite effective and quite fast acting. One instance where you may want to use an IL-17 is if somebody, let's say, has an important event coming up, a wedding or a birthday party, and they have a flare of their psoriasis and they need to be cleared quite quickly, an IL-17 may be useful in that regard. And then we have something called IL-23 inhibitors. So this is a very safe and very effective, just as a lot of the other medications are, class of biologic. This one you could expect to see pretty good benefit within about 1 to 3 months. The good thing with this class of biologic is the injections tend to be much fewer as opposed to the, let's say, IL-17s, where it's usually taken every 2 to 4 weeks. The IL-23s are usually an injection every 2 to 3 months. So this might be more appropriate for somebody who, let's say, is more needle phobic, doesn't want to be poking themselves very often. Every 2 to 3 months is actually not bad. That's about 3 or 4 times a year. Examples of this category are guselkumab, also known as Tremfya, risankizumab, known as Skyrizi, and tildrakizumab, known as Ilumya. That's one of the newer ones. Okay, and then lastly, as I was kind of mentioning on one of the previous slides, we are now starting to see a lot of these biosimilars starting to come to market. And this is because the patent has run out on a few of the medications that have been around for a while. So now there's a bit more competition and we're getting these things called biosimilars. It's not a generic because a generic drug is made of small molecules that are chemically synthesized and are usually molecularly identical to their brand name reference. Whereas with biologics, just due to the size, the complexity, and the natural variability of the biologic drug, biosimilars are not considered identical. But they're a similar molecule that clinically, and as far as the safety profile, are almost identical. In that sense, they're very much similar to the molecule that they are derived from or similar to. And their safety and efficacy is very comparable. And so that kind of wraps it up for the medications that we have currently in terms of topicals and light therapy and biologics. But it's worth noting that there are a few newer medications that are in the pipeline. It's a little bit harder to talk about these ones because they're not Health Canada approved just yet. Some of them are actually still being studied. One of them is actually approved in the States. That's the last one there, the TYK2 inhibitor, which is a systemic medication. But it's just showing you that there's newer medications coming and there is a lot of promise for psoriasis in the future for people who are maybe not responding to the current therapies that we have. The topical therapies are kind of exciting because there's a lot of steroid phobia and people may not want to use steroids. So for people that are more steroid averse and are not responding to, let's say, the calcineurin inhibitors, it gives us a few other options in the future to help with mild to moderate psoriasis. These are hopefully going to be approved within the next little while. Obviously, it depends on Health Canada, but they're kind of coming down the pipeline. As far as the systemics, like I said, that TYK2 inhibitor, which stands for tyrosine kinase 2, is actually already approved in the US. And this should be coming out, if not in early 2023, then probably by later 2023 here in Canada. That is a medication that kind of is a little bit less targeted and more broad in terms of what it affects in the immune system, but that could have a quite an important role. So for instance, if somebody has psoriasis, but they may also have another comorbidity like rheumatoid arthritis, you may want to not be so targeted. You may not want to block off certain cytokines, but more broad cytokines that are involved in both diseases. So a drug like this can actually play a role, or newer drugs that they're developing may play a role in that sense. So that's why I said it's not always the best option to be so targeted. Sometimes it actually makes sense to be a little bit more broad. And I think, nope, sorry, that was not the last slide. So working with your doctor and when to see a specialist. So really, there's no wrong answer to this. If the psoriasis is quite cumbersome, if it's affecting your daily quality of life, if it's something that you're struggling to get under control, family doctors, and this is not a knock against them, but they have a lot of knowledge about a lot of different things, but they may not know about the newest therapies or the latest therapies when it comes to certain things like psoriasis, which is why specialists exist. So that might be when you want to see a specialist. If you're not quite getting things under control, your family doctor's out of options, that's when they might get us involved. And it's a good conversation to have with your family doctor if you feel like you're not being quite adequately controlled and your psoriasis tends to flare and it's really affecting you. You may want to see a specialist at that point. Obviously, if you're moderate to severe and the family doctor, let's say, doesn't feel comfortable putting you on some of these newer medications or systemic medications, that's when they may refer you as well. And that's when you may ask for a referral, and it's appropriate to do so at that point. And if you would like more information that maybe your family doctor can't provide for you, that's when they may send you to a specialist. Even just ask questions and have a conversation about what's new and what's more appropriate for your particular case.